Hello, fellow zebra hunters. Welcome to an episode of Diagnostic Atypia, an open book podcast where we work and sometimes stumble through real life clinical cases with diagnostic twists and surprising endings. I'm Mike Arcieri.
And I'm Andrew Sanchez.
And we're residency friends who are now brand new hospitalists fresh out of residency.
That's right, Mike. Podcast, attending life, it's all new to us. Anyway, I think we've got a great episode for you today. So whether you're commuting to work, cleaning your apartment, out on a run, or one of the few who listen to podcasts without multitasking, thanks for tuning in and let's get started with another atypical journey.
Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed in all episodes is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant with key identifying details changed. All right, should we just go right into it?
Yeah, let's do it.
All right. So we have a 60-year-old man. He has really, as his most important past medical history, two big things. So really extensive peripheral arterial disease, has stents in the bilateral iliacs, as well as a superficial femoral bypass on the left side. Also has Hep C, never had cirrhosis, liver biopsy confirmed no cirrhosis, and he had cure with Harvani 2019. So for this podcast, about 6 years ago now. He had a colonoscopy actually 5 days ago, elective screening, where they just found a couple tubular adenomas. He's now coming in 5 days later to the emergency department with essentially severe back pain, intractable nausea and vomiting, and dysuria. He additionally is really not able to keep any food down, so he hasn't eaten anything during that period of time, and has lost some weight, he thinks, and also having some fevers and chills at night, usually accompanied by worsening back pain. That's sort of his initial HPI. He did not have any sort of symptoms directly after the colonoscopy. He was in the same system that you're practicing at, so you can see the PACU notes after, and it was a normal PACU course. He went home. These things sort of started maybe within 48 hours, sort of a slow onset over the 5 days. He's not sure, but there's no report in the notes that he ever had a Foley catheter placed during that procedure. And his labs at that time, a couple of days prior to the colonoscopy, were normal. He does not have any kidney disease at baseline, and he does smoke. And those are sort of the big things I'll give you. I'm happy to stop there. I'm also happy to give you some labs, whatever you prefer, Andrew.
I think it's an interesting place to stop. It's kind of a messy story, and it's very tempting when someone comes in after a recent procedure to try and link that procedure to what you're seeing in front of you. That's running under the assumption that what happened is causative of what you're seeing, but I also acknowledge that it can completely just be a correlation that this patient is coming in with these symptoms, and these symptoms were completely unrelated to the procedure he went through. But I think doing the exercise of making sure this isn't a complication of his recent colonoscopy is probably warranted. When I think of complications of colonoscopy, and you said a polyp was resected, is that right?
That's right. He had 3 polyps, all in the descending, all tubular adenomas.
Got it. Whenever you're doing like a polyp resection, there always is the risk of perforation. And if it's like a very big, complicated procedure, I often take care of these patients actually in the post-operative setting in the hospital for like 1 or 2 days, just to like monitor for perforation and bleeds. But I feel like that complication is usually pretty sudden. Like if this guy had the procedure and there was a perforation, he really should have like sudden onset kind of abdominal pain, and things should spiral out of control pretty quickly. And I feel like that's not what we're seeing here. So the back pain he was experiencing, I guess, could be like an atypical manifestation of kind of like peritonitis from like a perforation. But it sounds like this all happened kind of after he left and he was doing okay. So I think the time association is just a little bit odd. So, I mean, in terms of a direct complication of the colonoscopy, I feel like I'm having a hard time kind of linking those things together. And maybe this is all just correlation. So that's like the back pain frame. Dysuria frame is interesting. So if we follow the urinary tract and say, hey, this guy has new dysuria. Is that signal like an initial signal for a urinary tract infection and bacteria ascended into the kidneys? This guy could be having pyelonephritis, and that can certainly present as back pain. And in terms of this like intractable nausea, vomiting he has, that could totally be like systemic signature of pyelonephritis as well. If you only take the dysuria and you ignore the systemic symptoms, like the nausea, vomiting, then this would just be a simple UTI. But and of course, you don't even need to get a urine culture often in case like this. You can often just treat. But the presence of systemic symptoms here is rather concerning. And I think in addition to getting a urine culture in this patient, we actually need to go right to cross-sectional abdominal imaging and basically look for pyelonephritis. And of note, we need IV contrast to look for pyelonephritis. The sensitivity of a CT scan without IV contrast is not high enough to assess for pyelo. You're going to miss it. So if you have any suspicion for pyelo, you really need that IV contrast to amplify the sensitivity of that scan. In the workup of pyelonephritis, you can consider not giving contrast if you're purely looking for stone disease, because then the contrast will obscure radiopaque stones or hyperdense stones on the CT, and that'll give you a better look for stone disease. But I think in a guy like this, I'd prioritize infection and go with the IV contrast. So I don't know. That's kind of where my brain first looked. I think it's because of the kind of linear sequence of events of dysuria kind of going up to the kidney and causing a systemic signature. But other things that can cause back pain can exist kind of outside of, the retroperitoneal space, on the skin. Is there something going on locally there? In the back, in the spine, spinal abscess, things like this. So I think probably though prioritizing the retroperitoneal space, just given the ascending bacteria hypothesis is what I personally do. And what were the initial labs?
Oh, I love that discussion, particularly the push and pull of causation versus correlation with the recent procedure. I think it's so hard just not to. How can you possibly ignore that, right? And then the patient's telling you, this is definitely from my colonoscopy. So labs. So Chem7 notable for a new AKI to creatinine of 2.16. His baseline is 0.9. Normal BUN, actually. The rest of it is unremarkable, including a normal bicarb. He has a new leukocytosis to 17,000, neutrophilic predominance, no bands. And he has a mild anemia, 11.7, which appears to be long-standing. Normal platelets, liver enzymes, all within normal limits, and INR normal. His UA shows 3+ blood, 3+ leukocyte esterase, 2+ protein. He has pyuria, which is higher than the upper limit of our test, so markedly positive. Hematuria as well, and 2+ bacteria. FeNA is 0.9, so sort of just pre-renal by that definition, and ESR is 200. ESR is 78. CRP is 200. Those things were also obtained, and you have a urine culture that's cooking, a blood culture that's cooking, and his RVP was negative. Those are the things that we have when we walk into the emergency department. I'm going to stop there before any imaging, see if that changes anything for you, and then I'll give you some of the imaging as well.
Yeah, really interesting. I mean, I guess I'll start with the latter half of the data you gave, since I kind of am going down that path of, does this patient have a kidney infection? So, when someone has high-grade pyuria, that's certainly pointing you more toward an infectious hypothesis, in our case, pyelonephritis, ultimately nonspecific, any sort of irritation along the ureters, inside the kidney, in the bladder, anything that can cause that kind of inflammatory reaction can show that. It doesn't have to just be infection. If there were frank white blood cell casts, that would have been highly, highly, highly suggestive of pyelo, but we're not seeing that here. This is because when you have local pus, it'll literally cause kind of like stasis of flow inside of the kidney, and those white blood cells will literally clump together and cause you to see that. So we're not seeing that here, but certainly this inflammatory signal. I would still, given the systemic symptoms, want to scan this patient with IV contrast. As for the AKI, like what could be driving that? I mean, this is a guy who, it sounds like, isn't eating too much. There's a story for potential dehydration here. So I think in real life, I would be giving IV fluids, since it sounds like, and you really like a lot of IV fluids, like at least a liter or 2 liters. It doesn't sound like this guy has a heart failure history. And, if we want to get our answer for is this guy pre-renal or not, we got to make sure we give him enough fluids to actually kind of hypothesis test and get a real answer from that hypothesis testing. So I'd give this guy at least probably, if he tolerates it, 2 to 3 liters to be completely honest. And then if he doesn't respond, we do need to just open up the DDX to our intra and post renal causes. I guess just being, because I do want to be authentic to the exercise, Mike, maybe we just like stop there and you tell me kind of like what happened, because to be honest, I don't know if I think too much harder than this. So yeah, why don't we just pause there?
That sounds great. Yeah. And I think obviously you're oftentimes walking down to the emergency department with more of this data available. I'm realizing that I'm all about the physical exam. I didn't even give you the vitals. Let me give you that quick too. And then I'll give you sort of the whole story. So vitals, he's afebrile, heart rate 110, normotensive. He overall looks uncomfortable, but not sort of in distress. He's tachycardic regular. Nothing really otherwise cardiopulmonary. Rough remark. He has actually no tenderness to the back CVA area, and abdominal exam is also very benign. You're not able to elicit any tenderness. No suprapubic tenderness either, and that's sort of, I think, the most important. He's euvolemic, maybe a little dry on the mucosa, but not markedly so. You actually POCUS him to start and see that the bladder is small, decompressed, but that he has actually hydronephrosis on the right side. You're not able to elicit any pain as you're pressing there, but it's pretty clearly he's pretty clearly got a hydronephrosis. And so, like you said, you get a scan. The patient, unfortunately, initially declined contrast because he's like, I've heard that's bad for my kidneys. You're telling me I have a kidney injury. I don't want you to hurt my kidneys. And so, unfortunately, the initial scan is all non-con. And exactly like you said, you're going to miss a lot of resolution there. But I can read off that finding first on the non-con scan. So he has right-sided moderate hydronephrosis, and it abruptly tapers at the crossing of the iliac vessels. The bladder is unremarkable. The kidneys themselves also unremarkable, but again, no contrast on this initial study. No concerns for perforation. The colon looks normal. There's no edema. There's no fat stranding. There's no free air. There's no obvious lymphadenopathy, but what everyone's eyes are drawn to is that there's an increasing ill-defined soft tissue abutting and encasing the right common iliac artery anteriorly, laterally, and medially, so almost essentially every side. This soft tissue mass measures 3.6 centimeters in greatest dimension, normal caliber aorta, bilateral external iliac stents noted. Again, this is a non-contrast study. They say increasing, which suggests that there's a scan before this. When we talk to radiology, that is a typo. So there's no scan prior to this, and this is sort of a new finding. He's actually had a CTAP in January that did not show this, which is why we specifically asked radiology. So a cool twist. I'm going to stop there again and see what your thoughts are. He does indeed have hydro, though, and the hydro seems to stop right at this mass, which is encasing actually the artery at the site where the ureter crosses over the iliac vessels, which, if you remember the anatomy there. But yeah.
Wow, that's so interesting and very unexpected. So a couple of comments. I think we don't need to think extra hard about the AKI anymore. You can't get AKI from unilateral post-renal disease, unless if you have a unilateral kidney or a single kidney, of course. So this finding we're seeing on the right side of the hydronephrosis, this seems to be causing pyelonephritis by virtue of urinary stasis on that side. Whatever bacteria was living on that side is now festering and causing a kidney infection. We don't have the IV contrast to prove it, but I would say with 99% certainty there's probably pyelonephritis on that side based off of the dense neutrophilic leukocytosis you gave us, which needs an explanation. And the most common explanation for that is a bacterial infection. And it's just a perfect story for it. So I would say we probably don't need to prove that with an IV scan at this time. We could just treat empirically with ceftriaxone, and unless there's concern for a complication later on, there's really no need to kind of assess for complications of pyelo at this time. Everything just kind of fits and lines up nicely with that. So I anticipate this guy's renal function is probably going to get better with the fluids you gave him, since we know it's not post-renal, and we don't really have any concern for intrarenal disease at this time. So now our job is, or now our focus is elsewhere, because now we need to figure out why the ureter is obstructed there. That's really interesting. I feel like I heard an RLR case similar to this, where there was some sort of iliac disease in a patient with PAD, and I totally do not remember any of the discussion from that. I would be asking for further help from radiology with this, and maybe our vascular colleagues, just about complications of stents, because if there is the stent there and there's some sort of like leak around that area, that could cause maybe like a hematoma kind of like around the blood vessel, and then it slowly kind of compresses that side, and eventually that urinary tract infection then developed. But yeah, I think I would prioritize basically complications related to his known kind of like vascular disease there. And then if all that's exonerated, then I think we're worried about like stuff that's there that's not supposed to be there, like tumor, things like this, lymph nodes that are just like encasing the blood vessel. And really that's just a matter of like tissue sampling. And I really wouldn't be able to predict what that would be without that tissue sample. So I would say, prioritize hemorrhage and like hematoma in that area, because that could potentially get worse. And then beyond that, so we can think about things that are in the space that are not supposed to be there. So infection, cancer, abnormally enlarged lymph nodes, and that'll probably involve some tissue sampling. Well, what happened, Mike? This is super interesting.
Yes, thank you for playing along as always. We had, as usual, the similar thoughts, and so we talked to radiology, and they say, to answer any of the questions that you just asked, Andrew, you really do need contrast. They said it's so non-specific that it's going to be hard to give you more information without giving him some contrast. There's not been a complete response, but there's been a relatively good response to fluids. His creatinines come, I think 2.16, I told you, was the initial, sort of in the 1.5 range now, a day or two later after this fluid. It's not quite the robust response we were hoping for. And I'll actually just give you a little bit of an interesting caveat, because I think it's an important teaching point, is that actually renal was involved in the emergency department, and they actually asked for a cystatin C because it looked like he had actually lost a lot of weight. And the cystatin C actually did show some level of CKD. And so it's an important thing to remember that sometimes the creatinine is related to muscle mass. And so he probably doesn't have actually necessarily normal kidneys at baseline. And so there's some concern that this was really actually AKI and CKD, which may explain why he wasn't having the response we were hoping for. Either way, though, there's enough response that we feel okay giving contrast. And also, generally, if you need contrast, you need contrast, right? So it's given 48 hours later. And I'm just going to read you that report again. So again, the enhancing ill-defined soft tissue abutting and encasing the right common iliac is above. They say that there's still moderate right hydro to the same area. They also mention a left adrenal gland that's heterogeneously enhancing. It has been there for many years. And actually of note, this was worked up biochemically and was negative about 5 or 6 years ago. They're mentioning to consider a PET, and they really are not able to give you any more information about what this mass is, though, even with the contrasted study. Interestingly, this scan scans higher into the thorax and also mentions wall thickening of the distal thoracic esophagus, suspicious for esophagitis. Consider direct visualization to exclude lesion or neoplasm. So those are the new findings, or I guess the clarified findings. The esophagus being the one that is on this one, was not on the prior one. I'm just going to sort of let you know that, because I think you had also asked for tissue, this is a really challenging case from the pathology standpoint. We asked both interventional radiology and vascular. Vascular felt, just to answer your one question, this is not a hematoma or likely to be a complication of the stent itself. They feel like this is something external to the vasculature. They would not feel comfortable getting a biopsy, because this thing essentially is right on top of the stent. And so you could get erosion of the stent. Particularly, they'd be worried about an erosion of the stent erosion at the site of the stent, kind of through the iliac artery into the ureter, and actually creating a fistula, which would be catastrophic. Urology is also asked. They give the same answer, and then IR says that the tissue planes are so ill-defined that there's no safe way to do this. We're worried about the same thing. And so we're stuck in this situation where what we need is a tissue diagnosis, but we're completely unable to get any sort of tissue because the procedure not felt to be safe, presented at multiple different tumor boards, and no surgeon feels comfortable operating on getting this. So we obtain a PET, because I think the question now is, we've got this thing in the esophagus and we have this mass that we can't biopsy. Can we at least clarify whether or not there's metabolic activity to it? I'm going to read that to you as well, and then I'm going to pause again, if that's all right with you. The read on the PET is suspicious hypermetabolic soft tissue lesion adjacent to the right common iliac artery, cannot exclude involvement of the right common iliac artery. The esophagus was not PET avid. Remember, there was the distal thickening of the esophagus. That was not PET avid. They do mention a metabolically active mediastinal lymph node, which is likely reactive. Clinical correlation recommended, as always. I'm happy to have all these reports, right? There's tons and tons of there can be incidental findings or things that you're looking for clarification on. So let me know if there's anything you want me to, in terms of negative stuff, I can read to you. But I'm going to stop there. Gave you a ton of data and some management as well.
Yeah, that's really, really helpful. But I feel like I'm still left with the same question, which it sounds like is the same question you all were left to also. So we kind of thought through, was there esophageal malignancy that metastasized to a lymph node in the pelvis, and that just happened to want to invade around the iliac vessels? It sounds like that wasn't the case. PET avidity doesn't mean malignancy. It means that something is metabolically active, and it could represent infection too. So in this case, it sounds like everything else was rather incidental. So this would be a very, very strange focal infection, if anything, encasing the pelvis, that pelvic artery. But I think malignancy should be prioritized. And yeah, Mike, I don't know how else to make progress other than getting the tissue. And it sounds like nobody feels comfortable doing it. I don't know if general surgery is the last option, or they literally just go and open the patient up and very, very carefully take a sample themselves. And I probably would be asking them, just because it's causing the ureteral compression. We know it's invasive by nature of that, by virtue of that, and it may actually cause damage to that iliac vessel based off of how it's invading already, kind of along the lines of like fistula formation that was mentioned. So I'd kind of be worried that if we just sat on it, things could get worse. So I think we may need to talk to a surgeon to open up the patient and see if we can more carefully sample there, because I don't know how else to solve the problem otherwise. Very curious how you all approach this, though, and I'm very excited to learn from you today.
Yeah, this is the whole problem, right? It seems like it's a pathologic diagnosis we need, and then we can't get to it. Sort of two things I want to give you. One is that he does have Corynebacterium growing in that urine, so treated him for a complicated UTI. That UTI responds, but as we're sort of going back and forth in the hospital with these management decisions, he actually develops another UTI. And so the concern from urology is that this kind of hydronephrosis that's not resolving is now a nidus. And we're not going to he's going to continue to get UTIs. And so for that reason, also, there's an urgency to this. He actually ends up getting nephrostomy tube placed on the right side. But still, this mass is still there without explanation and without resolution. We did ask general surgery as well. And they said, vascular is your guy. And vascular said, we're not touching this. There's no surgical plane. We wouldn't be able to tell if we're dissecting into the artery on top of a stent. So basically, absolutely not. I asked 3 different interventional radiologists, and they all said no. So yeah, we will not get tissue. That's sort of what we're told. And so our approach really then is to try to think of a way we could make a biochemical diagnosis, or at least exclude things and narrow sort of through deductive reasoning. Can we get an idea of what this could be? We really narrowed in on, okay, let's take a step back. We have something in the retroperitoneal space, tumor, inflammation, something is there. And let's just sort of reframe this whole problem to retroperitoneal disease and let that guide our differential. How would we work that up if we can't get tissue? I'm going to pause there and just hear your thoughts on that approach, and also hear your thoughts on retroperitoneal disease as a problem with a differential.
Yeah, sure. One quick question. Was there anything visualized on the other side? It was really just all on that right side.
Totally unilateral. Yeah, just the right side.
Okay. Yeah, I asked that because if there were bilateral findings, like something similar to what we're seeing on the right, on the left, that would make us think of a variety of systemic infiltrative diseases that can live in the retroperitoneal space. We know that fibrosis can cause this. IgG4 related disease is associated with that. We know that some histiocytoses can do this, like Erdheim-Chester disease. And this is not to say, since we're not seeing anything on the other side, that excludes these things. Always the presence of findings is more convincing than the absence of findings. So I wouldn't take those things off of the table. Would probably just prioritize more kind of focal disease. And yeah, what really is in that space? The kidneys. We know radiologists can diagnose renal cell carcinoma, so I don't think that we're missing that. It's too high, right? So thinking lower down, closer to the iliacs. Lymph nodes are back there. Is this somebody who's been having B symptoms that he has kind of been brushing off and hasn't told anybody about? He's anemic. We know he has the polyps. That's why that was done. Is this something that's kind of causing some marrow suppression, or there's some marrow involvement too? Potentially. And beyond that, we've already talked about the blood vessels and how a hematoma compression can do this. We see kind of these patients come in with spontaneous retroperitoneal hematomas quite a bit in hospital medicine. I feel like not all of them have coagulopathy. Sometimes it's just happens from vasculopathy in kind of older patients. We've kind of entertained this idea of just hemorrhage in that area, kind of compressing the blood vessel. But yeah, I feel like other than fibrosis from something, reactive to radiation, autoimmune disease, or from cancer like histiocytosis, lymph nodes, lymphoma, and then hemorrhage. I'm not sure if I could think of anything else that would kind of be in there. So, just playing the game that you all played, this is just brilliant work on your part, Mike. This is such a hard case. I don't know if I would have gone this far. This is, I'm just so impressed by how you all did not give up on this guy, and you thought of every possible serologic way we could try to get this guy an answer. I would say, going through the list of things I just gave, for the autoimmune diseases, very, very insensitive, but there's IgG4 levels that you can send. IgG4 is also associated with kind of atopy and kind of allergic findings. So you get to an IgE level. And for the both histiocytoses and lymphoma, you can send an LDH, kind of your lymphoma detecting hormone for lymphoma. And hemorrhage, I mean, we've already kind of entertained that. I don't know. I mean, we have, of course, tumor markers for other things, but that would mean it started elsewhere and then came to the retroperitoneal space. So I don't, and we did the PET scan, so I don't think we're missing anything like that. So I'm not sure if there's anything else that we could have sent Mike other than that. But again, very excited to learn from you. What did I miss?
I mean, I think the most important pickup is that like retroperitoneal disease, is, I mean, IgG4 classic that's the sort of classic syndrome that's rare, but common amongst patients who present on the boards. And so we sent, again, as always, thinking right along the same lines as you. So we did send the IgG subclasses, which were totally normal, interestingly enough. ANA was negative, Onco was negative. You can see, very unlikely, right? Because you should have other symptoms, but you can see some autoimmune diseases that cause fibrosis, inflammation in the retroperitoneal space. Vasculitis, particularly if there's involvement of vasculitis at that stent, which is vascular said, no, that's not possible, but we sent it anyway. They were right because the onco was negative. Sent a C3 and it was markedly positive, actually really high, 206, so not really consistent with what I would expect for a complement mediated disease. And then we also sort of thought about what can metastasize there, or what neoplasms can show up there. And so you mentioned lymphoma, as LDH was normal, kind of upper limit of normal, but like 270, 280, not really something that's terribly impressive. And we did also obtain peripheral flow, and as well as the myeloma workup. The peripheral flow was normal. The myeloma workup did show 0.19 grams per deciliter of IgG kappa. Did talk to hematology. That's probably my weakest subject on the boards and real life. And they felt that this was MGUS, but very low risk, doesn't even need hematology follow-up, get SPEV, UPEP, IFE, free light chains, annually. Let us know if something changes. So it seems to be a red herring. The radiologist wanted us to get an MRI. The issue is that he had shrapnel in his abdomen. And so we were not able to get an MRI to better characterize this thing. So just another wrinkle in terms of in terms of trying to get better characterization of this mass. We can't get an MRI. We can't get a biopsy. The testicular cancer also can metastasize to the RP space. So we got testicular ultrasound, which was negative. We also got a PSA, which was negative. A TSH, actually, I sent. This was after our episode where we learned about...
Alex, shout out.
Choriocarcinoma. Choriocarcinoma, excuse me. And the TSH was normal. And TB will also can do this. And so we did, we just sent a T-spot, obviously not how you diagnose TB, but it was negative for what it's worth. And he did not have any risk factors. So those are the things we sent. And I'm going to pause there, see if there's anything else you'd send, see thoughts, and then I'll let you know. We never get to like a very definitive diagnosis, but I'll let you know what we do next. And I think how we can get to a probable diagnosis here.
Oh, I got nothing, Mike. Yeah, go for it.
Okay. So at this point, that's it. We've exhausted my brain, and we decide to talk to rheumatology because, again, this is something that needed a nephrostomy tube, which has its own set of complications going forward. And we'd really like to find a way to address this. Rheumatology feels that this is probably, just like you said very early on, IgG4 versus idiopathic retroperitoneal fibrosis, and said, you've done enough negative workup. We're pretty sure it's not lymphoma or infectious. So let's just treat with high dose steroids. And then, as long as he doesn't suffer some horrible side effect of the steroids, we'll see him in clinic in a couple of weeks with a repeat scan. So that's what we do. We initiate him on high dose steroids, discharge him. He is seen in rheumatology clinic probably 4 or 5 weeks later. Still has a nephrostomy tube at this point, has had no new UTI symptoms or signs, has done pretty well. A little of insomnia, it sounds like from the note from the steroids, but otherwise tolerating them pretty well as well. And the repeat scan does show a marked decrease in the size of the mass. And so they feel that this is part of that IgG4 versus idiopathic retroperitoneal fibrosis, sort of that continuum syndrome. And they plan to sort of continue to taper the steroids, consider steroid sparing agents if it doesn't continue to decrease. And hopefully the plan is to take out the nephrostomy tube at some point. At this point, his renal function is close to normal, his baseline, which again, I mentioned the cystatin C told us a little bit CKD, but close to it. So again, I don't have a tissue diagnosis. We can't know for sure what this was. And I think that was part of why it pushed us. Because maybe if we got the diagnosis on day 3 by pathology, this wouldn't have been a very interesting or it would have been a very short presentation. But I have a couple quick things to mention, but I wanted to just get your reflections first.
Yeah. What a cool case, Mike. I think my major takeaway, I mean, other than the beautiful bread and butter you presented on getting to pyelonephritis, kind of moving beyond that and kind of getting to the diagnosis of what seems to be more of a unilateral retroperitoneal invasive disease. I think where I went wrong doing a cognitive autopsy and how I want to improve for next time is really along the lines of what I was saying earlier about the absence of findings is less compelling than the presence of findings. Like unilateral focal disease doesn't rule out a systemic disease like IgG4 related disease. I have this bias where if I want to invoke a systemic infiltrative disease like IgG4, I have a much easier time if I see, oh, they have pancreatitis, they have retroorbital masses, they have lung masses. When you start seeing things in all of these different multifocal places, I think it's much, much easier to more confidently ascribe that process to something like IgG4 related disease. And I have seen cases of isolated IgG4 like in just like valvular masses on Cardio Nerds podcast. There's a case report on that someone had sent to me. But I just have a really hard time thinking of those things when it's so focal. I mean, it sounds like you guys even PET scan this guy. And I don't know, a lot of incidental stuff was seen. Maybe some of those things were related to IgG4. It just wasn't really considered. But I mean, just saying no, that those aren't related. Yeah. I mean, you have to keep those things on your radar. And I mean, kudos to you all for even coming with a game plan for this patient. That's a very hard path to take. And I think it's so cool that we already have a follow-up answer for this patient. And yeah, what teaching did you have, Mike?
Just a few very short points. One, you mentioned that the IgG subclasses are not sensitive, so they're pretty specific. They can definitely help you, but the absence of IgG4 elevation does not mean the patient does not have IgG4 related disease. That was a learning point for me from rheumatology because we had sent that. It was negative. We thought case closed. It's definitely not going to be that then. And our question for them was really more of like what do we do next? Not, does this person have this? So that was a really important learning point for me to know these test characteristics. The second, I think, also is that unilateral IgG4 disease is definitely possible in the retroperitoneal space. It's definitely the less common presentation for sure. But I definitely was able to find some case reports, which we'll put on the website, about patients with a very similar presentation. Actually, there's one that's almost looks to be like it's like this patient presented to them first of a guy with back pain, AKI, and then found to have a unilateral mass that was, and again, very similar. The issue with, I think what I'm realizing as I'm reading through the literature is that this often can arise from sort of the adventitia of the vasculature, so of the iliacs, of the aorta, of the thoracic aorta, which makes biopsy extremely hard and dangerous. And so it seems like this is not an uncommon problem, and rheumatology was actually not as shocked that we could not get this tissue, that this was sort of almost part of what gave them their pretest probability, is this kind of case of a tumor near the vessels that no one wants to operate on. That's almost kind of like part of the presentation, I guess, the illness script for them of this, because it just, that's where it tends to be. And it tends to have this story of like, we can't get a biopsy. And so you see in this case report, which I'll add, similarly, they didn't have, there's no pathology as well. So that was sort of the next thing. And I think the last was just really the reflection of sometimes what we can do as internists is to provide negative results and things that it couldn't be, or at least trying to reduce the risk that when we give someone a empiric diagnosis or a tentative diagnosis, that we're not going to cause harm in the treatment of it. So one thing I was really scared about was if this is lymphoma and we treat it with a bunch of steroids, right, then we're not going to be able to get a biopsy. He did have this other like lymph node in the mediastinum that I mentioned. We also asked for a biopsy of that, and it was not safe to do that for totally different reasons. Just the anatomy was tough. So we were hoping maybe we could get from that some sort of tissue then, that maybe it was the same process, but interventional palm, GI, thoracic, none of them felt that this was a safe mediastinal lymph node to biopsy for totally unrelated reasons. So really very tough. But again, if he has lymphoma and you blast him with steroids, then that's, it'll treat it for a little while, but you're not going to, that's obviously not the approach. And certainly if he had some sort of chronic infection, that would be the other concern, right, of hitting someone with really high dose steroids. So sometimes what we do is we provide reassurance that this empiric treatment is safe enough to try. And so I think those were my 3 learning points from the case. And yeah, I really appreciate you playing along.
Yeah, brilliant teaching points. I've never thought about how IgG4 causes this fibrosis, like where the fibrosis occurs and how it can kind of constrict blood vessels like this. I'm actually really happy you brought up the comment on how rheumatology sees this all the time, because now I'm thinking back to my IgG4 script on how it can cause aortitis. I've just never thought about how, that could be like a very challenging diagnosis. You have to, if you want to get tissue there, I mean, you risk rupturing the aorta. Yeah, I've never considered that before. Just brilliant teaching all around. Thanks for bringing this case, Spike. Looking forward to the next one.
This has been Diagnostic Atypia with Drs. Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us, dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.